relevant to our day-to-day fertility practice and often makes a critical difference to cycle outcomes. And we are truly privileged to have with us Dr. Sheetal Jindal as today's speaker. She is known for her strong clinical acumen, evidence based approach, and her ability to simplify complex concepts into clear, practical take home messages. And we are confident this session will be both insightful and clinically enriching. And we are also honored to have with us Dr. Umesh Jindal ma'am as expert. As we all know, ma'am is a pioneer in the field of reproductive medicine, a mentor to many of us, including me, and a guiding force behind Jindal IVF. Her experience and perspective always add immense value, and we look forward to her expert insights during the discussion. So, thank you all for taking out your valuable time to join us today. Without further delay, I would like to invite Dr. Sheetal Jindal to begin the session.
Okay. Yeah, thank you, Sonal, for such kind words. So I will begin my session, and the topic which was assigned to me was the luteal phase support in ART. Now, luteal phase is one of the most important phases in the menstrual cycle because this luteal phase is meant to support the pregnancy which can happen, and that is what the luteal phase is all about. It is the period which begins shortly after ovulation and ends either with luteolysis shortly before the menstrual bleeding, if in case the pregnancy does not happen, or there is an establishment of pregnancy after which during which the corpus luteum is rescued and is called corpus luteum of pregnancy, and then this corpus luteum further supports in the growth of the pregnancy. This corpus luteum secretes various hormones like progesterone under the influence of luteinizing hormone and other hormones in the form of estrogen and other growth factors which are essential to prepare the uterus for implantation and the development of embryo. Now, this function of the uterus for implantation and development of embryo is known as uterine receptivity. We can see the various changes which occur during the luteal phase. There is further, the glands become rich in mucus. There is further coiling of the spiral arterioles, and along with that, there is intense stromal edema which occurs. All this is required for the embryo to implant into the uterus. Now, one very important feature of the luteal phase is called the window of implantation, which is very relevant to all the ART practitioners. And this implantation window is the short interval which is seen in the mid-luteal phase during the mid-secretory phase, when the endometrium is most receptive to blastocyst formation. It is this period which usually begins on day 22 to 24 of an ideal 28-day menstrual cycle, and it lasts less than 48 hours. And there are a lot of molecular markers which are released during this window of implantation in the form of integrins, cytokines, and various other factors. One of the most important factor is the leukemia inhibiting factor, which immunomodulates the endometrium and so that the endometrium becomes receptive. And during this window of implantation, the endometrium, which has been primed by estrogen and progesterone, the various changes which occur in this endometrium is collectively called as endometrial receptivity. And it is in this window of implantation that there is an endometrial embryo crosstalk, which leads to the implantation of the embryo. And before and after this window of implantation, there cannot be any implantation which can occur into this uterus. So now coming straight away to what is luteal phase defect. Now, luteal phase deficiency is a condition in which the endogenous progesterone is not sufficient to maintain a functional secretory endometrium and allow normal embryo or implantation and growth. It is seen in 8 to 10% of the natural cycles also. Now, this luteal phase defect is something which is a little controversial controversial in natural cycles, but yes, what we usually imply is that in case there is a bad follicular phase, if the follicle which is developed is not of a very good quality, then it might lead to a bad luteal phase, meaning thereby the progesterone production by the corpus luteum might not be adequate to support the endometrium, and it can lead to a luteal phase defect, and which might not allow the implantation to happen. Now, luteal phase can occur because of two reasons. First, I said, as I already said, it could be because of when there is the deficiency of the secretory activity of the corpus luteum, which is very commonly seen in all the ART cycles. In natural cycles, this luteal phase length is approximately, it lasts from 11 to 14 days. But whereas in a hyperstimulated cycle, this luteal phase is shortened because of various reasons, which I'm going to describe in the next slide. And there can be another type of luteal phase in which the corpus luteum is normal, which means the progesterone production is normal, but the endometrial response, the endometrial changes to that progesterone production is not appropriate. And this also leads to a relative luteal phase defect, which is very commonly seen in endometriosis and in some females with polycystic ovaries owing to high LH in them. Now, in ART cycles, luteal phase defect occurs because of the most common use of GnRH agonists and antagonists. What happens in the intact cycle in antagonists, we use GnRH antagonists during day 5 to day 7 of the stimulation to inhibit the LH surge, and this LH surge inhibition is important to prevent premature ovulation. Now, these antagonists, they directly inhibit the endogenous LH, which leads to a sort of LH deficiency during these stimulation cycles. And in long protocol, in which GnRH agonists are used from the previous cycle, this GnRH agonist also inhibits the release of LH by direct pituitary inhibition, which leads to deficiency of LH in the subsequent stimulation. And both these lead to a relative luteal phase defect, relative deficiency of LH, and this LH deficiency cannot support the corpus luteum to secrete progesterone. Additionally, for stimulation to mimic the natural surge, we use HCG as a trigger in most of the ART cycles, and HCG by its ultra short feedback loop also inhibits the release of endogenous LH. All these lead to decreased deficient progesterone production, and this leads to luteal phase deficiency in most of the ART cycles. Also, there is improper quality of corpus luteum formation. We aspirate the follicles, and most of the granulosa cells are lost during they get aspirated also, and they are lost also while the ovum pickup is being done. And we all know that these granulosa cells are the ones which in the future are going to become the lutein cells. And so there is an inappropriate corpus luteum formation, which leads to decreased secretion of progesterone by the corpus luteum. And also the supraphysiological E2 high estradiol levels also have a direct luteolytic effect on corpus luteum. All these factors, they lead to relative deficiency of LH, and which leads to luteal phase deficiency in most of the ART cycles. Now, just to point out what HCG does in HCG trigger, to overcome this LH deficiency, we use HCG as a natural surge to mimic the natural surge in all the ART cycles. And this HCG bolus causes a rapid increase in the progesterone concentration. And the progesterone concentrations, they become very high post pickup in the initial 2 to 3 days. Now, this high HCG can lead to endometrial advancement. And the peak progesterone concentration, because of high HCG, there is a surge of progesterone from the ovaries, and this is very, very high, and this occurs mostly on day 2 to day 3. So that is why there is a drop in concentration time implant of the embryo
Doctors,
has to occur, which is around day 18, 19 of the luteal phase. And all these cause a relative. So what happens is, because of this, there is an endometrial and embryo asynchrony which occurs. The endometrium advances, so the proper bed for the embryo to implant probably is missing, and that is why there is a relative luteal deficiency which occurs when HCG is used as a trigger. So in a nutshell, lack of endogenous LH and the use of unphysiological triggers, this LH as we can see is
I request all participants to please mute yourself. Dr. Suman,
so
Dr. Ashwath.
So basically, because of this lack of adequate LH, which is seen commonly in, as I have already explained, this leads to inadequate progesterone production and relative luteal phase defect in ART. Now, because of this, there is improper production of progesterone, and high levels of HCG cause an endometrial follicular asynchrony, shifting the window of implantation, and and this most and because there is an asynchrony, most of the when the blastocyst is entering the endometrial cavity on day 5, this apposition, adhesion, invasion and penetration of the blastocyst might not take place because of the improper timely secretion of all the important molecules which I have mentioned over here. This window of implantation is altered, and this leads to luteal phase defect in ART cycles. This is again the same thing. So the same thing which I am showing, that if we are using a GnRH agonist trigger in antagonist cycles, the luteal phase is also very short, because GnRH agonist has a very short half-life of just 24 hours as compared to the natural surge. And HCG also has a very long half-life, which leads to endometrial advancement. All these factors, they lead to luteal phase defect. So now this basically forms the rationale for using luteal phase support in pregnancy in most of the ART cycles. So if you want to do a fresh transfer, you definitely need an additional progesterone support because of lack of LH. There is progesterone deficiency. Or you might like to freeze all the embryos because of this luteal phase defect, or if you are suspecting any hyperstimulation. Or with the use of GnRH agonist, you can use either estrogen plus progesterone as an intensive support. Just if you want to mimic the natural.
Dr. Gurpreet, can you please mute yourself?
We want to mimic the natural environment. And so there are various ways in GnRH agonist trigger. We can use the European approach or the American approach. I'm not going to go into the details of this extensive luteal phase support, but yes, it involves use of estrogen and progesterone, mimicking all the molecules which are secreted by the corpus luteum in the luteal phase to support the pregnancy. And there are other additional agents which can increase
Dr. Gurpreet, I please request you to mute yourself. Dr. Gurpreet.
Okay. So coming to, once we know that luteal phase support is an essential component of ART, so what are the options of luteal phase support which are available to us? So if we want to support the endometrium and complement the production of corpus luteum, there are various types of preparations to support the endometrium, which is in the form of progesterone or estrogen preparations. And we can divide it into additional agents which support the corpus luteum by stimulating the release of LH, maybe in the form of HCG. HCG can directly stimulate the HCG receptors in the pituitary and can increase the release of LH in the LH and increase the production of progesterone indirectly. GnRH analogs are also believed to do that. We can directly give recombinant LH, though the dose becomes very high and it is very expensive, so it is not routinely used. And there are additional agents which can improve the blood supply and endogenesis during the luteal phase in the form of sildenafil and other ecosprin and all those drugs, heparin. These are also used for the implantation of the embryo of the blastocyst.
Ma'am, can you please tell which route and dose of progesterone delivers the best outcome?
I'm coming to that.
Okay,
so the various progesterone preparations which are available to us, the armament which are available to us are in the
Sheetal, let's have a break here.
Okay.
So, in other words, you want to say that all IVF cycles would require luteal phase support?
Yeah, absolutely.
So that's one thing which is very clear, that practically all IVF cycles with all kinds of regimes are luteal phase deficient for various reasons which you have enumerated.
Yes.
So that's one very important take home point. Then the add-ons which improve implantation, and the agents which actually support luteal function, you would like to separate out that,
Yeah, yeah. So
like
basically,
sildenafil and all their add-ons.
they are add-ons. So you can either directly, prime the endometrium, estrogen primed endometrium with progesterone, or you can indirectly stimulate the release of progesterone from the corpus luteum by, stimulating maybe the pituitary, or so there are some agents which work at that level. And there are few agents which can just improve the blood supply so that the overall drug which is administered, which is delivered, or, maybe just the factors which we want should reach the embryo, they can be improved with the help of additional agents like heparin, ecosprin, and all. So this is the concoction of the entire luteal support which we would like to give to the growing to the blastocyst which we are going to transfer.
Because most of the gynecologists, when they see the prescriptions of ART specialists after luteal phase, when they actually get shocked that so many medicines are being prescribed. So, what do you think?
Yeah, yeah. Yeah, so there are, I mean, I will just come to those controversies which are there. I'll try to enumerate them. Whether, you want to give two routes, you want to give one route, because we have a lot of preparations which are available to us, and I would just, try to clarify on that also. So the various progesterone preparations which are available to us are the oral micronized progesterone, but we have to understand that this oral drugs, because of the this progesterone, it gets degraded into the GI tract. It has low bioavailability, and it is associated with various adverse events also. So oral drugs are not in much use in our ART cycles. The second route, which is very commonly used, is the micronized vaginal progesterone. This is definitely preferred over oral because of its ease of use, but it has its own limitations in the form of vaginal irritation. Sometimes patients do complain of discharge and irritation. So it can be administered in the form of gel or as capsules. The one very commonly used agent is the intramuscular progesterone, and which gives us sustained progesterone levels throughout. But it is definitely painful because it is most of the progesterone injections initially used to be oil based, and it does use patients will very commonly complain that they have a small lump which is being formed, and if they have to take injections for 2 months, it becomes very painful. And in few cases, there could be a formation of micro abscesses also. And one very potent agent which is favorite of a lot of people is this oral didogesterone, which it is an oral progesterone with improved bioavailability, and this is also very commonly used. Now, coming to the progesterone doses, so there is not much work which is being done on which dose is ideal. But yes, these are the most commonly doses, and ISHRE also recommends these doses which can be used. It could be the intramuscular injections are available either in the form of 50 milligrams once daily, and there is something which is, I forgot to mention, aqueous progesterone also, in which the polarity of the progesterone molecules is changed so that they become water soluble, and they can be given subcutaneously, and they are very much in use nowadays. Then progesterone gel, the common term is Crenon gel. It is 90 milligram of gel in a bioadhesive form, which is used vaginally. Then capsules in oil are available in the dosage of 200 milligrams, and they can be, the doses variate. The variation is from 600 to 800 milligrams. It is 200 milligrams single tablet which is available, and you have 100 milligram doses also which are in starch suppositories. And there is a 400 milligram BD vaginal pessary, which is common sustained vaginal pessary vaginal tablet which we get.
Why so many doses are available? And
I think
It is
progesterone progesterone has its use in so many, there are so many indications for progesterone use. They are used for preterm labor also, threatened preterm labor. And there are so many, there's so many areas where progesterone is being used, and plus the absorption. And uh, I think that is why, according to me, that is the only reason why there are so many doses which are available for progesterone. If there's something else to add, probably you can.
I
I
think
think it is very interesting that despite multiple trials, we still do not have any perfect protocol to be labeled as luteal phase support in IVF. So it itself
Yeah,
tells us that it is like LPS is as individualized as COH. Like as we individualize COH in patients,
yeah.
similarly we have to individualize luteal
And
phase
I
support.
think, yeah, Sonal, that is very true. And I think the dosage, because the preparations are in oil or they are in starch, so I think there is a minimum kind of dose which I think the pharma people can probably answer that why we have such
yeah,
multiple doses which are there in IVF
actually
for use in,
yeah, very few studies have been done on the pharmacokinetics of progesterone with various routes. And
yeah,
what
yeah,
exactly matters is perhaps the endometrial progesterone levels, which are
yeah,
usually not measurable directly.
Yes,
yeah,
So
yes,
you
yeah,
can either measure the serum levels. So serum levels may not represent the endometrial levels. So ultimately, you have to go by the clinical results.
yeah,
yes,
So
true,
now a lot
ma'am.
of studies are coming for about serum levels also, and
yeah.
maybe two route administration is perhaps a good way. I think that one theory is also coming now. Okay, instead of single
Yeah,
route,
I
you
mean, you
should
can
opt
go
for.
on and on and on in luteal phase. There
Yeah.
is so much to say, but
But
yeah,
yeah. So
yeah,
actually,
yeah,
there is no standard protocol. I think every hospital has their own protocol according to their experience, rather than standardized protocol.
Yes, ma'am.
yeah. So now, as I already told you, so if we talk about the pharmacokinetics of these progesterone preparations, oral, I have already told that only because of the hepatic bypass, only 10% of it gets absorbed, and it causes side effects like sedation and hypnosis. This is not a very preferred route. And progesterone in oil basis, probably it gets rapidly absorbed in 2 to 8 hours, and it is able to maintain its level after 72 hours. But it is patients might not be very compliant with it. And vaginal is like a targeted organ delivery. It causes, if you are giving vaginal progesterone, the serum concentration of the progesterone might be lower, but it does lead to high concentration in the uterus and endometrium. That is what we want. And there are very few systemic side effects, and patients find it much easier to use, and self administration is possible. So now coming to all the questions which we have with luteal phase support, what is the ideal time for starting luteal phase support after pickup in cases of fresh embryo transfer? Now, I think there is a lot and lot of literature which is available on starting a luteal phase support. People have recommended its use immediately after pickup to up to 96 hours. They have studied, various, when you can give. The ideal reason for so many timings is that because HCG initially 2 to 3 days, the HCG surge is able to take care of the progesterone secretion, and once the secretion progesterone comes down, that is the time when we want that the progesterone concentration should be at its peak. So that is why people have done studies with different timings. But according to the ISHRE, guideline on ovarian stimulation, what is suggested is that luteal phase should be started in the interval time between the evening of the day of the ovum pickup to any time day 3 post oocyte retrieval. So this is the time between which, not after that. If you are if you are starting the progesterone, then obviously the pregnancy rates, they definitely fall. So any time between this, we can start the progesterone with whichever route we want to start. Now, which route is most preferred? Now, vaginal progesterone is the most preferred route, and it has equal efficacy as compared to intramuscular or subcutaneous routes. So I just want to describe here a meta-analysis which actually, it was done by Paul Zarutsky in 2009, and it compared progesterone gel. Before that, most of the interventions, most of the progesterone which was used was in the form of intramuscular. And after they compared 3 arms: progesterone 50 milligrams intramuscularly daily versus 200 milligram progesterone in oil capsules versus 90 milligram gel. It had included 9 RCTs, and the outcome which they studied was the clinical pregnancy rate and the ongoing pregnancy rate. All the 3 had comparable effects with respect to clinical pregnancy rate as endpoint. Rather, vaginal gel was considered to have slightly lower miscarriage rate. And so this one study, this meta-analysis, it shifted the administration, shifted the use of shifted to the use of vaginal progesterone as compared to intramuscular progesterone in ART in most of the fresh cycles. And then if we talk of, coming to the most recent analysis on the evaluation of progesterone supplementation for luteal phase, I'm so sorry, I think there is some confusion over here. So this was an evaluation of progesterone supplementation for luteal phase in fresh IVF cycles. And this study, this analysis, meta-analysis concluded that intramuscular progesterone is probably the one which should be used. The greatest benefit was observed when progesterone was supplemented intramuscularly versus vaginally, because now it is said that vaginal absorption of progesterone can be different, and it might not be it might not be the ideal way. And so recently there is again an upsurge of there is sufficient literature which says that intramuscular progesterone probably is superior as compared to the vaginal progesterone. And coming to the timing in natural, people have compared various timings to giving the progesterone to as low as till beta HCG positive to up to 12 weeks. And there is a wide variation again in this. I will come it to later on. But in this meta-analysis, the progesterone supplementation was ceased after less than 3 weeks. And they said that clinical pregnancy rates were equivalent if you are stopping it once UPT is positive and maybe 1 week later, or if you have continued up to 12 weeks. So now coming to the route of progesterone administration, again, I just want to tell you this was a very interesting meta-analysis in which 26,726 women were included, and clinical pregnancy rates were found to be much higher with the intramuscular as compared to the vaginal or subcutaneous or oral route. And the greatest the odds ratio was approximately 1.37. And in this, co-administration with estrogen in the luteal phase was not found to be of any benefit at all. Now, coming to the various drugs which can be used in the luteal phase, during the luteal phase, one is the use of HCG. Why we want to use HCG as a luteal phase support is because it can directly act on the pituitary and stimulate the release of endogenous progesterone production by the corpus luteum. In the beginning, ma'am must have seen that, ma'am would know it better, that we were using 1500 to 2000 international units of HCG, and it was given at various intervals in the luteal phase to support the corpus luteum. But now it is considered that it is a very, very strong luteal phase support, so it should be avoided. And HCG is usually given with GnRH trigger in cases of extensive luteal phase support, the European approach. And it can be given in the dose of 1500 international units on the day of OPO once, if you have used a GnRH trigger, just to support if you want to do a fresh transfer, it will just support the luteal phase. But you have to be careful with the risk of OHSS in case, in such a scenario, if you have too many follicles, freeze-all would be a better strategy. Something new which I read was that nowadays people are using microdoses of HCG in the form of 100 to 150 international units, and they are given at various times throughout the luteal phase without the use of progesterone. And it is said that it is able to achieve serum progesterone levels of 75 nanomole per gram per liter, and it is sufficient. This is what is the optimum in for the growth and implantation to occur.
I think these micro doses are still very few reports are there, not
Yeah,
widely
but I
accepted.
found it very interesting, so I thought
Yeah,
that
it's interesting.
fresh transfer,
Yeah.
yes.
But the HCG dose during luteal phase, I think we used to give routinely in the beginning, but it was very risky. I do remember that few patients landed up in OHSS because of this. And if you are now to give it with GnRH A trigger as an extensive support, I think this again very risky because JNRH is A is usually given when there are more number of follicles, and if you
Yeah,
support HCG during luteal phase, then the whole purpose is gone. So,
yeah.
so
Yes, ma'am.
So when
the
you have to wait, and
placentotrophic
in
and a
case you feel
luteotrophic
that,
hormone, yeah,
yeah, so if you feel that the chances of patient landing up in OHSS are a little low, and you have used only a GnRHA trigger just to be on safe side, and you want to
yeah,
do a fresh transfer, probably then you can add 1500
yeah, like dual
international.
trigger you have given, you can give in those cases in poor responders, and you have four
Yeah.
five follicles. In those cases, definitely you can.
Yeah.
So, any questions from the audience? If you have any, please interrupt or you can just write in the chat box. So, yeah, carry on, Sheetal. If there is any question, we'll answer that.
So
Sonal, you have any question?
Yes, ma'am. Ma'am, ma'am is explaining very beautifully. First, as we all know that luteal phase support is mandatory in ART cycles, and after that, various routes. I would like to ask about adjuvants. I think ma'am will be covering in the later
yeah,
slides.
yeah. So I have tried to take the commoner adjuvants because the list is endless. So I'm just covering, there is an recent interest, and I saw a lot of articles which were written on the administration of GnRH agonist in the luteal phase support. Now, use of GnRHA in the mid-luteal phase causes flare-up response, and it can cause release of LH and can support the corpus luteum. So that is why usually once we are doing on the day of the blastocyst transfer, it is advisable, and some people advocate that you can definitely give GnRH agonist a short dose of 0.1 or 0.2 milligram, and this can help in it can increase the progesterone production, and maybe it can just give a better luteal phase support. So this supports the implantation of the embryo at this time, which then and once the and it can the down regulation before the down regulation sets in, probably if the implantation has occurred, the embryo will start secreting its own HCG, and then this can further help in progesterone production. Also, there are certain direct receptor that it has a direct action on the receptors which are present in the endometrium or on the embryo, and thus it can help in implantation. So there are multiple studies which have shown benefit of adding GnRHA in both fresh and frozen cycles, but still the overall quality of data is lacking. ISHRE still says that it should be used only in the context of a clinical trial and on research only, but there are definitely papers, and I think we will see more and more data about the use of GnRHA in luteal phase support in the mid-luteal phase. Now, coming to low-dose aspirin and low molecular weight heparin. Now, low-dose aspirin, we all know it decreases the thromboxane A2 is to prostaglandin ratio, and it causes vasodilatation and decreased platelet aggregation. Now, this low-dose aspirin can increase the ovarian and endometrial blood flow and increase ovarian responsiveness, and it might help patients with thin endometrium by improving their endometrial thickness. But all these are just speculations. What is important is that ecosprin probably is known to decrease uterine contractions at the time of endometrial embryo transfer. And heparin also, we know that these are all blood thinners, and they can prevent placental thrombosis and infarction, and maybe they help in promoting establishment of pregnancy. So heparin is very commonly used for its immune modulation properties, and there was an article in Fertility Sterility in June 2017 which said that these agents might have an immunomodulatory role although the overall evidence in the support of their use is weak, but most of the bodies they do not recommend. But I think Ecosprin and heparin are a very common prescription which are seen with most of the ART specialists. It could be an overprescription, yes, but most of the ART specialists are using it. Now, coming to luteal phase support in frozen cycles, once the patient, these days frozen cycles is the norm. We are doing more and more frozen embryo transfer cycles. But once the embryos are frozen, we have an option of transferring the embryo either in a natural cycle or a modified natural cycle or a stimulated cycle or an artificial cycle. Now, in natural cycle, we are depending naturally on the corpus luteum progesterone production, and I will just discuss about that later in my later slides. Or we can do it in the modified natural cycle where we are giving external agents to for ovulation to occur, and then trigger is given in the form of HCG rather than the spontaneous LH surge. This is basically the stimulated cycle in which you are using external agents. Modified natural cycle is in which we are triggering with HCG, just to time the embryo transfer. And most commonly used is the artificial cycle in which we are giving exogenous drugs in the form of estrogen and progesterone for the development of the endometrium. And there is no corpus luteum, there is no ovulation, so it is totally an artificial cycle which is used. Now, in most of the HRT cycles, we are giving estradiol in the form of 2 milligram, 4 to 6 milligrams from day 1 or 2 of the menstrual cycle, day 2, 3 of the menstrual cycle till day 11, till the endometrium is approximately 7 to 14 millimeters. And from there, the progesterone is added and then followed by the subsequent embryo transfer. Now, in HRT cycles, the day the progesterone is administered is considered as day 1, and the embryo transfer is usually done on day 6 of the progesterone. We all know this. And and usually it is said that the 6 days of progesterone supplementation is sufficient enough to make the endometrium receptive. There are various papers on it. So that is why a blastocyst transfer is planned on 6th day of the cycle, or maybe on the 7th day, depending on depending on the the type of depending on the embryo growth of the embryo which you have. In most
Ma'am,
of the
can
time,
you please tell about, do you routinely do serum progesterone levels after starting progesterone and before
yeah.
transfer? And
So I'm just coming to that, Sonal. I'm just coming to
okay,
that.
ma'am.
So now my focus is mainly on the artificial cycle. So what are the challenges of luteal phase support in HRT cycle? We know that there is no corpus luteum, and that is why there is a lot of, initially in most of the frozen cycles, intramuscular progesterone was used, which used to give sustained levels, and probably that is why in most of the HRT cycles, intramuscular progesterone gives highest clinical pregnancy rate and ongoing pregnancy rate. But because of the pain and because you need someone to administer, vaginal progesterone in the form of gels or tablets is the preferred route in most of the frozen cycles. This is what is being used. But what is the current recommendation is, although there is a lot of controversy on it, that serum progesterone levels, they should be checked depending on the route of the administration. And once we are using a vaginal progesterone, it is now advised that serum progesterone levels should be checked. Now, so this was a study in which so this was one study which established the non-inferiority of vaginal progesterone, and it was compared with daily intramuscular progesterone for replacement in HRT blastocyst transfer cycles. And its main aim was to assess non-inferiority of vaginal progesterone with intramuscular progesterone, which was administered every 3rd day compared with daily intramuscular progesterone. So the intervention was that blastocyst transfer was randomized into 3 arms. One was only intramuscular progesterone which was given, and in the second arm 200 milligrams vaginal gel was given twice daily. It was given, and in the third, gel plus this intramuscular progesterone was also given. So the pregnancy outcomes was seen in all the three groups, and this was something which was very important to note, that only with the use of vaginal arm there was the biochemical pregnancy losses were probably the highest, and the clinical pregnancy was lowest in the only vaginal arm, and it was statistically significant. So this trial was stopped, for the frozen cycles, because vaginal only arm had increased miscarriage rate and decreased ongoing pregnancy rate, and which was to the tune of, which was statistically significant. So this made people think that whether vaginal progesterone as the only route in frozen embryo transfer cycles is relevant, or is there a need to add any additional agent. So, and along with that, people also notice that the serum progesterone levels, might not be sufficient in case we are using only one route, maybe in the form of vaginal progesterone. And people started measuring serum progesterone levels, and progesterone levels from there are various studies which are quoting, but usually a progesterone level of 10 nanogram per ml is considered. That should be there on the day of embryo transfer in most of the frozen cycles. And progesterone levels more than 10 only were considered to be optimum for the optimal clinical pregnancy rates, and levels less than 10 were associated with lower ongoing pregnancy rates as compared to those higher levels. So people started doing serum progesterone levels one day prior to the embryo transfer, just to see whether, and there was something which was called as rescuing the transfer cycle, either by adding an additional progesterone through a different route, so as to get comparable outcomes. So this rescue progesterone, which was in patients with in which one day prior to ET serum progesterone levels were lower than 10, they were adding rescue progesterone in the form of either subcutaneous progesterone, or in the form of maybe whichever route of rescue progesterone was used. They were able to they were able to give good reproductive outcomes as compared to those in which the progesterone levels were adequate. So this was this low progesterone in which rescue progesterone was used, they were able to the clinical pregnancy rate and ongoing pregnancy outcomes were almost similar as compared to the one in which normal progesterone was used. Now, so now if we compare subcutaneous progesterone versus vaginal progesterone supplemented with intramuscular progesterone, so there are various studies in which this subcutaneous, either vaginal progesterone or subcutaneous progesterone has been supplemented. The subcutaneous or vaginal progesterone has been supplemented with intramuscular progesterone every third day in the various HRT cycles. And most of these results have said that in case you are using intramuscular progesterone, either with subcutaneous or with vaginal progesterone every third day, the progesterone levels became comparable, and definitely it resulted in the improved ongoing pregnancy rate. And so I want to especially describe about dydrogesterone. So in a nutshell, in case you are using only vaginal progesterone, it is always a good idea to add an additional route of progesterone so that serum progesterone levels are sufficient. Now it is itself a controversy that whether serum progesterone levels after the vaginal route, they will be less because of the first pass effect. But still, there are n number of studies which say that in case you want to have an ongoing pregnancy rate which is comparable, it is a good idea to add progesterone either in the form of there are various regimes which have been described. Either it could be a subcutaneous progesterone, or it could be an intramuscular progesterone every alternate day, every third day, so that you can have better pregnancy outcomes. Now, this was a use of dydrogesterone, basically the drug which we all know is in the form of Dufestin. It is also used in HRT cycles, and we had this Lotus 1 and Lotus 2 trials in which 30 milligram of dydrogesterone, initially dydrogesterone came with phase 3 randomized control trials, which was done, and it compared 30 milligram of dydrogesterone with micronized vaginal progesterone 600 milligram for luteal phase support, and it said that and it said that this is non-inferior, and Lotus 1 demonstrated non-inferiority of dydrogesterone to micronized vaginal progesterone with respect to clinical pregnancy rate and ongoing pregnancy rate. So that is how oral progesterone in the form of dydrogesterone is used quite frequently now. And then Lotus 2 trial was done to establish its non-inferiority in the fresh IVF cycles, in which it was again a multicentric randomized open label non-inferiority trial across 35 centers, and it also established this superiority of, it also established the extensive use of dydrogesterone in routine clinical practice in the IVF cycles. So further, this oral dydrogesterone has been extensively studied in the in frozen cycles also, and this meta-analysis, which was very recently published in 2025, it also suggested that oral dydrogesterone could be used similarly to vaginal progesterone. It can be an additional route also, or it may just replace the vaginal progesterone in most of the FET cycles. Although we still need more data, but yes, dydrogesterone is going to stay.
Ma'am, for the frozen cycles, as you mentioned already, either we are doing artificial cycles or natural or stimulated cycles. Can you briefly tell us like how the progesterone dose differs in the artificial cycle and natural or stimulated cycle as per your experience? Because we have corpus luteum definitely in natural and stimulated
Yeah,
cycle.
so I think we are currently using 100 milligrams of intramuscular progesterone in our center routinely for most of the for most of our patients. We are totally using intramuscular progesterone because it gives a sustained level, and that is why we use it, because we need not measure the serum progesterone levels. But in case you are willing to use, if you want to use progesterone in the form of gel or maybe the tablets, then 400 milligrams twice daily, or maybe 90 milligrams of Crenone gel you want to use. In those scenarios, it is advisable that you do a serum progesterone level, and depending on the levels, maybe you can just add an additional route of progesterone, maybe in the form of dydrogesterone, or subcutaneous progesterone can be added, so that probably then you can get better results. So this is what is advocated nowadays for most of the frozen cycles. For frozen cycle, progesterone.
I think for NRI patients, the combination of vaginal plus oral dydrogesterone is a very good combination, and they do fairly well on this combination. So because the injection administration is a problem for them when during travel and when they go back, it's a problem.
And plus, I feel that in a lot of cases of endometriosis, frozen cycles are done for a lot of reasons. So it depends. I think so. Oral dydrogesterone is probably in cases of progesterone resistance. It is either you increase the doses of the subcutaneous or vaginal, whichever route you are using, and along with that, you can definitely add dydrogesterone, which will which probably might help in these type of patients. So now the Foxy position statement on the supplementation of luteal phase support in ART is that progesterone supplementation is advisable starting just after oocyte retrieval, and dose of exogenous progesterone therapy is they recommend up to 10 to 12 weeks of gestation, and you can either use intramuscular progesterone 50 to 100 milligrams per day, or you can use this vaginal capsule, natural micronized progesterone 600 to 800 milligrams per day. Oral dydrogesterone dose is 20 to 30 milligrams per day, or gel is in the form of 90 milligrams, which can be used once daily. So we have this battery of choices, and depending on patient characteristics also, we can choose any of them. So now coming to, is luteal phase support required in natural cycle or modified natural cycle? And so it is now again, it is a controversy, because we have the corpus luteum, which will support the luteal phase in modified natural and natural cycle. But so our aim is to mimic natural secretion of corpus luteum. So moderate quality evidence, it suggests that progesterone luteal phase support is required in these cycles too. And it should be, it can be started 36 hours after the onset of LH surge when LH is measured in the morning serum test, or maybe 36 hours after the administration of HCG. So all RCTs are required. So this is what you do in a natural cycle. You do the serum LH levels, and once it is positive, 36 hours after that, you start with progesterone. Or if you are done, or if you and if it's a positive urine LH, then after 24 hours you can start. And in case you are using an HCG trigger, then 36 hours post trigger you can start the luteal phase support. Now, these are the different luteal phase protocols and luteal phase support in different FET protocols. And as I've said that, you can add the progesterone. I just described, 36 hours post the LH test positive. And in mild ovarian stimulation also probably it is the same. And in artificial cycles, once the triple line pattern is seen, you can start progesterone, and blastocyst transfer can be done on day 6 of serum progesterone. So till what time luteal phase support is to be given? For HRT cycles, it is said that till 12 weeks, we give it till 12 weeks, although a lot of studies are there which say that you can continue it till 10 weeks and then stop. So I believe that the luteoplacental, when the luteoplacental shift is happening, we don't know. And, I don't want unnecessarily patients to land up in bleeding or any other issues. So I'm a little scary, and I use it till 12 weeks so that I'm sure, I want to make sure that the complete shift has occurred. Although the luteoplacental shift starts as early as 8 weeks, and some people say even 6 weeks also, but then yes, it is a transition which occurs, and you can stop, depending on your own experience, you can stop it. For fresh transfers, it is recommended that till beta HCG testing or till 8 to 10 weeks, yes, we have a corpus luteum to support, so we can definitely stop it early. And the time period given is 8 to 10 weeks. And there are variations in the literature as to when you want to stop the luteal phase support. Now, coming to luteal phase support in IUI cycles, COH with IUI is also associated with supraphysiological E2 levels, and they inhibit the pulsatile LH secretion, which is important for the for the formation of corpus luteum and secretion of progesterone. And also these levels have luteolytic effects on the corpus luteum. So HCG trigger itself can advance the endometrial window of implantation, although the dosages which we use are lesser. So it is recommended that if we have more than one follicle, and in COH we aim to have more than one follicle, luteal phase support in the form of final vaginal progesterone can be considered. So this was a very recent, systematic review and meta-analysis which studied the efficacy of luteal phase support in COH-IUI cycles in mild male factor and unexplained infertility. There were 12 RCTs, and progesterone luteal phase support resulted in higher live birth rate than no luteal phase support or placebo. The relative risk was 1.38 with confidence intervals of 1.21 to 1.159. So, and it is luteal phase deficiency seen more in gonadotropin cycles. But overall, they say that we all know that the evidence is of low to moderate quality, but it is said that you should, you can use the luteal phase support in IUI cycles with controlled ovarian hyperstimulation. So I would like to conclude by saying that luteal phase support is a must in ART cycles, and progesterone is the main support. Vaginal progesterone, along with supplementation based on serum progesterone levels, can be considered. And intramuscular progesterone provides highest clinical pregnancy rate, ongoing pregnancy rate, but yes, it is painful. And luteal phase support can be considered till 10 to 12 weeks of pregnancy.
Thank you, Sheetal.
Thank you.
Thank you, ma'am.
I would like to share some experience with progesterone in oil injections. I think progesterone allergies are also common. What do you say?
Yeah, I think this is also one limitation of intramuscular progesterone, that we have encountered patients in which these allergies have happened because of there is one component in the, I think I've forgotten the name, which leads to, it's some alcohol based, I think, component which leads to uh, which could be the cause of pain, and allergies are definitely common. Not very common, but yes, we do see them. We do see
And
them.
also fever, some of our patients. What about that, ma'am?
Yeah, yeah. So in those scenarios, in case there is fever, then I would say that these are the patients in which we might have to shift to gels uh, and maybe some other route of progesterone. And there was a very interesting paper which said that shifting from one type of progesterone to another, we should not be very skeptical, because the pregnancy rates are similar in almost all of them. So in case you feel that the patient is uncomfortable, because we are using intramuscular progesterone and it is difficult to take, I totally admit it. And but in case uh, most of the patients are able to take it though, and
Would you
you
consider
can
shifting
shift.
it to vaginal plus dydrogesterone?
See, I did it for one patient, and I think I recently remember for one patient, and her pregnancy continued very well. So I think it's not that big of a problem. It
What
was
about
very clearly
IUI?
mentioned in that paper that we can shift in case there is some problem with any of the progesterones, combinations or something.
For
Anybody else would like to make a comment? Any of the audience?
ma'am, for luteal phase support in IUI cycles, what is preferred, oral dydrogesterone or vaginal micronized progesterone?
I think dydrogesterone is the only reason why the only reason why dydrogesterone is popular is because of its oral, tolerability, and its profile is like that. So there has been just one paper which, with some concerns about the heart defects and all, but that's just one paper, and before and after that,
Mm.
nothing of that sort has been heard. So that had scared a lot of people, but now still, we are just waiting for more literature, and dydrogesterone is going to stay. At least this is what is said. I usually prefer giving oral dydrogesterone as compared to micronized vaginal progesterone, because I feel that it's very cumbersome to, put the tablets inside
Yes,
every day. And,
mm,
it does cause
true.
discharge is a very common complaint which
Mm.
patients,
Uh, sh-
complain of.
We have one question in the chat box, ma'am. Dr. Ashwath wants us to repeat natural cycle luteal phase support, especially any role of estrogen and progesterone doses, also stimulated cycle.
Okay, so in a natural cycle, we have a corpus luteum, but yes, in case you are, so you want to know it for IUI or IVF?
Natural cycle IVF.
IVF.
So natural cycle IVF, generally we have a corpus luteum, but we can always use intramuscular progesterone in the dosages of, this aqueous progesterone is something which is very good. You can use it in the dose of 25 to 50, milligrams. Or you can use combined vaginal gels along with oral progesterone combination. Even that is okay. Even
I
just,
think
I
for
think
natural
just vaginal
cycle,
tablets or vaginal progesterone, vaginal gel is sufficient in these cases.
yeah, in natural cycle,
A
vaginal
single dose would be, a single route would be, should
is
be enough.
sufficient. Yeah.
It's sufficient.
Any more questions from the participants you would like to
I hope
take?
I made luteal phase support a little clearer, but yes, there is lots and lots and lots to, you know,
Actually, a lot of confusion is there. The more problem is a lot of confusion is there. But basically, any adequate regime that gives you,
So, according to me, just simple, intramuscular progesterone is sufficient, and maybe
yeah.
you can just add. I feel giving a small shot of GnRH agonist, makes sense. I do give it, but otherwise, giving progesterone, especially in frozen cycles, along with these few things, is just is just enough for a luteal phase support. We should keep luteal phase very simple, very simple.
And there's another question from Dr. Ashwath. Role of estrogen in natural cycle.
No, it is not. See, progesterone will act on an estrogen primed endometrium. So, in case you are doing a natural cycle, the estrogen is already there. Now, why people get confused with, to give estrogen is it's because, corpus luteum is known to secrete estrogen also in the luteal phase. But I think that is sufficient. There is, on the contrary, giving too much of estrogen from outside can be inhibitory also.
Yeah.
So in the
Actually,
luteal phase, progesterone only
yeah.
should be sufficient. Should be
Actually,
sufficient.
actually, estrogen is not required in natural cycle. It's also not required and not recommended in fresh transfers. Initially we were giving in fresh transfers for estrogens also, but that's again, there is clear evidence that estrogen is not required. Only in HRT cycles, estrogens started, which were there in the follicular phase, they have to be continued in the luteal phase, like you have estrogens in normal luteal phase. So
Luteal phase also.
there you have to continue. You don't have to increase or decrease the dose, and the same dose usually continues, which you were giving in follicular phase.
Or otherwise, in this extensive luteal phase support, in cases in which you have given GnRHA trigger, in those cases,
Yeah, in those cases,
estrogen
extensive.
has to be
In those
given.
cases, estrogen is recommended. Yeah,
Yes, yes.
and so no estrogen in stimulated cycles, IVF cases. In all cases, even in IUA cases, practically hardly there's any role of estrogen in the luteal phase. I think we can wind up here if
Yes,
there are
ma'am.
no more questions.
Yes, if there are any more questions from the participants, we would like to take. So, luteal phase support is all about precision and not excess. Knowing when to support, what to support with, and when to stop is as important as stimulation itself. So, when done right, luteal phase support bridges the gap between ovulation, implantation, turning good cycles into successful pregnancies. That is
Well,
what we all
Well
want.
said. Well said. Well said, Sonal.
So we look forward to have you all in our upcoming clinical round series. We have more sessions coming up every fortnightly. We'll be sharing the schedule with all of you. So thank you all for having you with us. So have a
yeah.
very good evening.
Thank you, thank you, thank you,
Thank you, ma'am.
thank you.
Thank you.